Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. I'm Louis Krause from the Pacific ADA Center, your moderator for this series. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, technical assistance, and other information as needed on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the CC icon in your meeting control toolbar. To turn on your meeting control toolbar permanently, press your Alt key once, and you can then press it again. As always in our sessions, only the speakers will have audio. The audio for today's webinar is being broadcast through your computer. Make sure your speakers are turned on or your headphones are plugged in. You can adjust the sound by navigating to the audio settings on the bottom panel. You can adjust the sound by sliding left or right on the soundbar in the audio tab. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128, or you can dial 1-646-558-8656 and use the webinar ID of 760-897-977. I do want to remind everyone that the webinar is being recorded and it will be able to be accessed on the adapresentations.org website next week in the archive section of the healthcare area. This webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modification of policy issues under the ADA, the Americans with Disabilities Act of 1990. Upcoming sessions are available at adapresentations.org under the Schedule tab. Then follow to Healthcare. These monthly webinars occur on the fourth Thursday of the month at 2:30 Eastern, 1:30 Central, 12:30 Mountain, and 11:30 a.m. Pacific Time. By being here, you are on the list to receive notices for future webinars in this series. Those notices go out 2 weeks before the next webinar and open that webinar to registration. You can follow along on the webinar platform with the slides. If you are not using the webinar platform, you can download a copy of today's PowerPoint presentation at the Healthcare Schedule webpage at adapresentations.org. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform, and the speakers and I will address them at the end of the session. So feel free to submit them as they come to your mind during the presentation. And there on your screen, you can see, you can type your questions in the chat text box area, or if you are using keystrokes only, press Alt-H and enter text in the chat area. If you are listening by phone and not logged into the webinar, you may ask your questions by emailing them to adatech@adapacific.org. That's adatech@adapacific.org. If you experience any technical difficulties during the webinar, send a private chat message to the host by typing in the chat window. And again, type your comment in the text box and hit enter. If you are using keyboard only, you do Alt-H to access the chat box and enter your comment. You can also email us at adaTech@adapacific.org, or you can call 510-285-5600. Today's ADA National Network Learning Session is titled Physical Access in Healthcare. The Americans with Disabilities Act, the ADA, is a civil rights law that enhances equal opportunity for people with disabilities. In this session, two members of the ADA National Network will provide an overview of the physical access requirements for different types of healthcare facilities. Physical access elements addressed will include general ADA requirements, parking, passenger loading zones, and drive-through medical testing, building and office accessibility, accessible exam rooms and waiting areas, and accessible medical diagnostic equipment. Today's speakers are Jan Garrett. Jan is the program manager for the Pacific ADA Center, and Emily Shuman. Emily is the deputy director for the Rocky Mountain ADA Center. All right, Jan and Emily, I'm going to turn it over to you now.
Great. Emily, I believe you start.
Yeah, I think we can go to the next slide. All right, well, thank you, Lewis, and thank you everyone for being here. As you just heard, my name is Emily Shuman, and I'm the Deputy Director of the Rocky Mountain ADA Center. So we have quite a bit to get through today and hopefully leave some time for questions. Today's agenda, we're going to be covering ADA general concepts and applicability, parking, passenger loading zones, and drive-through medical testing, building and office accessibility, accessible exam rooms and waiting areas, and accessible medical diagnostic equipment. Next slide. Our learning objectives today are going to be to understand how the ADA applies to healthcare facilities, identify areas of healthcare facilities in which physical accessibility is required, and learn how to address common barriers to access in healthcare facilities. Next slide. So we really can't overstate the importance of ensuring physical accessibility in healthcare. Accessibility of doctors' offices, clinics, and other healthcare facilities is essential in providing medical care to people with disabilities. Due to barriers, individuals with disabilities are less likely to get routine preventative medical care than people without disabilities. Accessibility is not only legally required, it is important medically so that minor problems can be detected and treated before turning into major and possibly life-threatening problems. Next slide. Now, I'm sure this group already knows a lot about the basics of the Americans with Disabilities Act, but for those who might not be familiar, I want to give a brief overview of the law and requirements that apply to healthcare. The Americans with Disabilities Act of 1990 is a federal civil rights law that prohibits discrimination against individuals with disabilities in everyday activities, including medical services. A person with a disability is someone with a physical or mental impairment that substantially limits one or more major life activity, a person who has a history or record of such an impairment, or a person who is perceived by others as having such an impairment. The ADA does not specifically name all of the impairments that are covered. The ADA ensures access to the built environment for people with disabilities, while the Department of Justice enforces accessibility standards. When the law was first passed in 1990, the ADA included standards for accessible design, which were amended in 2010. These new standards are referred to as the 2010 Standards for Accessible Design. Next slide. The 2010 Standards for Accessible Design are not outlined in the ADA law itself. Rather, these guidelines are developed and updated by the U.S. Access Board. These standards apply to places of public accommodation, commercial facilities, and state and local governments. The 2010 standards became enforceable in 2012 for all new construction, alterations, program accessibility, and barrier removal. Much of what we will talk about today came directly from the 2010 standards for accessible design. Next slide. In most cases, healthcare facilities are going to be subject to the ADA requirements outlined in Titles 2 and 3. Title 2 applies to state and local government entities and includes public hospitals, clinics, and medical offices operated by the state or local government. Title 3 applies to public accommodations and includes private hospitals, clinics, or other medical offices. Under Titles 2 and 3 of the ADA, medical care providers must provide individuals with disabilities full and equal access to their healthcare services and facilities and reasonable modifications to policies, practices, and procedures when necessary to make healthcare services fully available. Next slide. All buildings, including those built before the ADA went into effect, are subject to accessibility requirements for existing facilities. Under Title II, a public entity must ensure that its program as a whole is accessible. This may entail removing architectural barriers or adopting alternative measures such as relocating programs to accessible locations. Under Title III, existing facilities are required to remove architectural barriers where such removal is readily achievable. Barrier removal is readily achievable when it is easily accomplishable and able to be carried out without much difficulty or expense. If barrier removal is not readily achievable, the entity must make its services available through alternative methods if those methods are readily achievable. So that's what you need to know as far as the general ADA requirements. So now we can move on to the specifics, and we'll start with parking. Next slide. The 2010 standards define a parking facility to be inclusive of both parking lots and parking structures. The number of spaces required to be accessible is calculated separately for each parking facility and is not based on the total number of parking spaces provided in all of the parking facilities provided on the site. Next slide. Here you can see the chart found in the 2010 standards that outlines how many accessible parking spaces are required based on the total number of parking spaces provided in a parking facility. A common misconception here is that the requirement is a certain percentage of the total applied across the board, but that's not the case. You really do have to consult this table to come up with the correct number of accessible spaces. Next slide. The 2010 standards outline additional requirements for parking at hospital outpatient facilities. It requires that 10% of patient and visitor parking spaces provided to serve hospital outpatient facilities are accessible. Now, the 2010 standards does not officially define outpatient facilities, but it does note that this section is intended to cover facilities or units that are located in hospitals and that provide regular and continuing medical treatment without an overnight stay. The standards also note that doctors' offices, independent clinics, or other facilities not located in hospitals are not considered hospital outpatient facilities. Next slide. The standards also have requirements that apply to rehabilitation facilities and outpatient physical therapy facilities. 20% of patient and visitor parking spaces provided to serve these facilities that specialize in treating conditions that affect mobility and outpatient physical therapy facilities must be accessible. Conditions that affect mobility include conditions requiring the use or assistance of a mobility aid, such as a brace, cane, crutch, prosthetic device, wheelchair, or powered mobility aid, arthritic, neurological, or orthopedic conditions that severely limit one's ability to walk, respiratory diseases and other conditions which may require the use of portable oxygen, and cardiac conditions that impose significant functional limitations. Next slide. For every For every 6 or fraction of 6, that is anything below 6, parking spaces required to be accessible, at least one shall be an accessible van parking space. So for example, if you have 9 accessible parking spaces required to be accessible, 2 of those must be van spaces. Next slide. Accessible parking spaces that serve a particular building or facility must be located on the shortest accessible route from parking to an accessible entrance. Where parking serves more than one accessible entrance, accessible parking must be dispersed and located on the shortest accessible route to the accessible entrances. In parking facilities that do not serve a particular building or facility, accessible parking spaces shall be located on the shortest accessible route to an accessible pedestrian entrance of the parking facility. There are a couple of exceptions. Van accessible parking spaces can be clustered on one level of a parking garage, and accessible spaces required for one parking facility can be located to another parking facility if doing so results in substantially equal or better access in terms of travel distances, parking fees, or user convenience. Next slide. Car accessible spaces must be at least 8 feet wide and marked to define the width. An access aisle of at least 5 feet wide is required next to the space. Next slide. Van accessible spaces must be at least 11 feet wide, which is 3 feet wider than the regular accessible spaces. This is to provide room for vehicle ramps and lifts. Alternately, this extra width can be added to the access aisle instead of the parking space, which results in an access aisle of at least 8 feet wide, the same width as the parking space. A vertical clearance of at least 98 inches is required for van spaces and vehicular routes serving them. Next slide. The access aisle provides room to transfer to and from vehicles and must adjoin an accessible route to an accessible entrance. 2 spaces can share one access aisle. Users will pull in or back into spaces depending on which side the access aisle is needed. Access aisles must extend the full length of the parking space. The access aisle must be marked to discourage parking in them. The marking method and color is not specified in the standards, but may be addressed by state or local regulations. Access aisles cannot overlap vehicular ways. If van spaces are angled, the access aisle is required to be on the passenger side where vehicle ramps or lifts typically deploy. Next slide. Parking space and access aisle surfaces must be stable, firm, and slip resistant. Access aisles must be flush with the parking space. Changes in level other than slopes up to 1 to 48 are not permitted in either the access aisle or the parking space. Curb ramps cannot protrude into any portion of the access aisle or parking space. Next slide. Accessible parking spaces must be identified by the international symbol of accessibility. The term van accessible is required on signs designating van spaces and can be provided on a separate sign or added to the main designation sign. Signs are required to be at least 5 feet high from the finished floor or ground surface measured to the bottom of the sign. This allows spaces to remain visible when occupied. Signs installed on circulation paths must provide headroom clearance of at least 80 inches. Signs can be installed on posts, suspended from ceilings, or fixed to walls. Next slide. The 2010 standards also address access to passenger loading zones. Where provided, an accessible passenger loading zone is required within every continuous 100 linear feet of loading zone space or fraction thereof. In general, the requirement only applies if a passenger loading zone is provided at the discretion of the entity. However, the standards do require a compliant passenger loading zone at several types of facilities. Next slide. Medical care and long-term care facilities where the period of stay exceeds 24 hours, parking facilities that provide valet parking, and mechanical access parking garages are all required to provide at least one accessible passenger loading zone. Next slide. Passenger loading zones shall provide a vehicle pull-up space at least 8 feet wide and 20 feet long, and an adjoining access aisle is required. Next slide. Passenger loading zone access aisles must adjoin an accessible route and not overlap the vehicular way. They must be at least 5 feet wide, as long as the vehicle pull-up space, and must be marked to discourage parking in them. Next slide. Vehicle pull-up spaces and access aisles serving them must be stable, firm, and slip resistant. Access aisles must be at the same level as the vehicle pull-up space they serve. Changes in level greater than 1 to 48 are not permitted. And a vertical clearance of at least 114 inches is required at the vehicle pull-up space, the access aisle, and along vehicle routes connecting them to vehicle entrances and exits. Next slide. Okay, so now that we've covered arriving to a medical facility, let's talk about getting into the building. For this, the ADA requires an accessible route. Accessible routes are what permit people with mobility disabilities to safely travel from site arrival points to accessible entrances. At least one accessible route must be provided within the site from accessible parking spaces and accessible passenger loading zones, public streets and sidewalks, and public transportation stops to the accessible building or facility entrance they serve. Next slide. Accessible routes must coincide with or be located in the same area as general circulation paths. Where circulation paths are interior, required accessible routes shall also be interior. Next slide. Accessible route, floor, or ground surfaces must be firm, stable, and slip resistant. Next slide. Walking surfaces should have a 5% maximum running slope. Ramps should have a 5 to 8.3% maximum running slope, and cross slopes should never exceed 2%. Next slide. Walking surfaces should be free from gaps greater than 1/2 inch and vertical changes in level greater than 1/4 inch. Vertical changes in level up to 1/2 inch should be beveled at a 1:2 ratio. Gaps and changes in level can be caused by broken concrete, potholes along an accessible route, or a threshold at a door. Next slide. Pathways should be 36 inches wide except at doors and for short distances when it can be narrower at 32 inches wide. Next slide. Ramps which rise more than 6 inches will need to have both handrails and edge protection. Edge protection is a method which prevents a crutch or wheelchair wheel from running off the side of a ramp. Ramps must also have level landings at the top and bottom of each segment and where the ramp changes direction. Next slide. Accessible entrances are part of the accessible route and ensure people with disabilities have a way to get into the facility. At least 60% of all public entrances must be accessible. Because this is the minimum requirement, if a facility has only 2 entrances, both must be accessible to meet the 60% minimum. If direct access to a facility entrance is from a parking structure, each direct access entrance must be accessible. If direct access to a facility entrance is from a pedestrian tunnel or elevated walkway, at least one direct entrance to the facility must be accessible. Next slide. Revolving doors, revolving gates, and turnstiles are not allowed as part of an accessible route. Where double doors are used, at least one side of the double door must be accessible. In general, door openings must have a clear width of at least 32 inches. This requirement varies slightly in certain conditions, such as with door openings more than 24 inches deep. Nothing can protrude into the doorway below 34 inches from the ground. Protrusions between 34 and 80 inches above the ground cannot protrude into the doorway more than 4 inches. Thresholds at doorways can be no more than ½ an inch high. Entrances must comply with the same ground floor surface and changes in level requirements as the rest of the accessible route, which we covered a minute ago. Next slide. The 2010 Standards for Accessible Design outlines requirements for maneuvering clearances at doorways, which varies based on the type of door. And you can see on this image on the slide that there are many different configurations for types of doors. Next slide. Operable parts of doors, such as handles, pulls, latches, and locks, must be operable with one hand and shall not require tight grasping, pinching, or twisting of the wrist. The force required to activate operable parts must be 5 pounds maximum. Operable parts of doors must be at least 34 inches and no more than 48 inches be above the ground. Door closers must be configured so that doors close after at least 5 seconds. Next slide. Okay, now we'll turn to drive-through medical testing sites. Drive-through medical sites are one way that healthcare providers can offer intermittent medical services with greater ease and safety for patients. Of course, we've seen this come up a lot with the recent pandemic and testing for the virus, but you might also see this for other reasons, such as during flu season to give flu shots. Typically consisting of pop-up tents and traffic cones, these temporary sites may be in a parking lot at the hospital, a retail store, or a state fairground. The sites are especially useful for medical testing during times of an outbreak, since keeping patients in vehicles can help to minimize exposure to a contagious disease. Whether these drive-through medical sites are funded and operated by state and local governments or a private business, the Americans with Disabilities Act requires that the services are accessible to people with disabilities. Next slide. In terms of physical access, the most important consideration at a drive-through site is access to wheelchair users. As we discussed earlier, minimum clearance for wheelchair accessible vans to approach and pass through the site is going to be 8 feet and 2 inches high, or 98 inches. Next slide. For patients who use wheelchairs to exit their vehicles at the drive-through site, if that's needed, there needs to be an access aisle alongside the vehicle. As we covered, the access aisle must be at least 60 inches wide if the lane is 132 inches wide, or 96 inches wide if the lane is 96 inches wide. Next slide. It may be necessary to provide walk-up services for those who cannot drive on site by vehicle, such as someone who is blind and doesn't have access to a ride. In these cases, there must be an accessible route to access all elements of the testing, such as check-in, testing, paperwork areas, check-out, and so on. Staff should always be on hand to help direct those who are in line for walk-up services. Okay, so that is my time, and now I will pass it on to Jan, who will tell you more about the inside of healthcare facilities.
Great. Thank you, Emily. Next slide, please. So Emily addressed some of the accessible route issues for the exterior of the facility, and many of them are the same for the interior of the facility. You still need generally a clear width of 36 inches. You also need a passing space of 60 inches for every 200 feet. So that is, if you have a really long corridor or hallway, you need to make sure that you have a passing space if you have that that is more than 200 feet long. You can have no changes in level, as Emily mentioned, more than a 1/4 inch or a 1/2 an inch if it's beveled at 1 and 2. The running, which is also known as the forward slope, can be no greater than 5% or 1 in 20. And the cross slope, again, the side-to-side slope, should be no greater than 2% or 1 in 48. It should also be firm, stable, and slip resistant. Next slide. So as Emily mentioned, there are some exceptions about when the walking surface can be narrowed. One of those exceptions is at doors, which we're going to talk about in a moment. But the clear width can be reduced to 32 inches for a length of 24 inches maximum, provided that those reduced width segments of 24 inches long and 32 inches wide are separated by segments that are 48 inches long minimum and 36 inches wide minimum. So this can occur both interior and exterior to a facility, but if you have some reason to narrow down the walking surface, then you need to comply with this requirement. Next slide. So in addition to width requirements, firm, stable, and slip resistant, and those kinds of issues, there is also some exceptions about multi-story buildings. Generally, every story and every part of every story and mezzanine in a facility must be accessible, and you must be able to get to all those accessible stories. However, there is an exception for an accessible route between floors that is known as the elevator exemption. This is for private sector facilities only that are less than 3 stories, and that story can be above or below grade, or less than 3,000 square feet per story. Although the 3,000 square feet per story buildings are quite unusual, I would say. But generally, this is for private sector buildings that are fewer or less than 3 stories, and that you do not necessarily have to have an elevator in new construction. Next slide. However, you must have an elevator, or in other words, the elevator exemption is not allowed when you have a shopping center or mall with 5 or more sales or retail establishments. And note that that number of 5 or more can vary by state law. When you have a professional office of a healthcare provider, and here we're talking all about healthcare and physical access today. So note that if you have a professional office of a healthcare provider, you cannot put that office on the 2nd floor of a building without an elevator and be able to receive the elevator exemption. Also, in terminals, depots, or stations that are used for public transportation, you need to have elevators. And as we mentioned before, this elevator exemption is for private facilities, but there is an exception to the exemption, which says that government facilities can have an elevator exemption where they are 2 stories only, and where 1 story has no public space at all, and a maximum occupancy of 5 people on that 2nd story. So a very limited exception for government facilities, but generally note that the elevator exemption would apply only to private or Title III facilities. Next slide. So let's talk a little bit about employee work areas and other exempt areas in a building. Generally, mechanical spaces are exempt from accessibility requirements because those are only usually accessed by personnel who have to maintain the equipment in those spaces. Also, employee work areas generally must comply with accessible route requirements, egress, so that means you can exit the employee work area, and visible alarms when you have audible alarms in that area. So you would need to have visible or strobe type alarms in those employee work areas when you have audible alarms and wiring for those. Also, employee work areas need not comply with accessible route requirements if they are less than 1,000 square feet. Again, this is an area that could be different in state law, so note that. Next slide. So this is a slide that is showing a medical care suite overhead look at it. So this is showing on the upper left-hand corner a mechanical area that would be exempt. Even in new construction, you would not have to make that area accessible. And it's also showing employee-only work areas, such as a reception file, reception or file area for staff on the left-hand side, a nurse's station on the right-hand side, and a janitor's closet on the right-hand side. So those areas, employee work areas, would need to meet the approach, entry, and exit requirements, but not all the other accessibility requirements, even in new construction. Next slide. So doors, Emily did talk a little bit about doors already, but generally, to reiterate, doors have to have a 32-inch clear width. And if the door is more than 24 inches deep, and in some older buildings, or even sometimes in new construction, that you might build a door that has a 24-inch depth, but then the clear width needs to be 36 inches wide in order to allow somebody to be able to maneuver and pass through the door. Again, it can have no projections into that clear width of 32 inches below 34 inches. And that is so that a wheelchair can pass through and not get caught on any projection. Also, you should have lever handle hardware as opposed to knobs, and that hardware should be placed between 34 and 48 inches above the floor. That may vary in your state codes. And door closers, which is the device that makes the door close once it's opened, cannot project more than 4 inches if they are below 80 inches, so into the clear floor space. And that is because those door closers can become a protruding object. And that means that someone who's blind, if some object is between 27 inches and 80 inches off the ground, and it projects more than 4 inches into the circulation path, or that could include a doorway, then that blind person would not detect that item by their cane. They would not detect that protruding object, and therefore that object cannot protrude more than 4 inches into that doorway or into any kind of circulation path. I also want to mention here that on the right of the door that you see, you would typically place signage for people who are blind, and permanent rooms and spaces must be marked by signage that has braille and tactile elements, and there are specific requirements for where that sign must be placed in terms of the height of the tactile elements and the braille elements, and where the sign should be noted. So that's something that also should be provided, is signage in interior spaces. Next slide. So we're going to talk a little bit about maneuvering clearances. This provides a minimum space for positioning and maneuvering at doors for people who use mobility devices of any kind. Keep in mind that somebody with a mobility device, whether it's on the push side or particularly on the pull side of a door, needs to be able to open that door and move the door around their mobility device in order to be able to then enter through the doorway. So that's why maneuvering clearances, which are shown in these two photos in yellow, are particularly important. And we're going to talk about that some more, and also with regard to restrooms. Next slide. So maneuvering clearances can actually overlap in certain areas. They're, of course, required at each accessible door based on the approach and the swing. Again, whether it's a push or pull, and what approach you're making, whether it's from a forward approach, the latch side of the door approach, the hinge side of the door approach. So the maneuvering clearances will vary by that. But here you see actually that maneuvering clearances can overlap. And that is important to note when there might be multiple doors, but it needs to be basically 48 inches of clearance in this kind of situation, and include and make sure you're accounting for the actual swing of the door and the width of the door with that 48 inches when you have multiple doors in a series. Next slide. So there is also an exception or an interesting part of maneuvering clearances for doors that include an offset. So the maneuvering clearance is generally measured from the wall, and that's because the door is typically flush with the wall. If the door is offset from the wall, in other words, indented a little bit from the wall, it cannot be offset more than 8 inches from the face of the door. Next slide. So here it is showing in these two figures in the maneuvering clearances. So on the left-hand side, you see a maneuvering clearance where the door is recessed 8 inches maximum, and the maneuvering clearance is allowing for an 8-inch maximum recess on that door. So the maneuvering clearance ends right at the wall. However, on the right-hand figure, if you have to recess the door greater than 8 inches, then the maneuvering clearance is going to have to move inward toward the wall and the door that are recessed, and you're going to have to provide a strike side or latch side clearance that allows you to actually maneuver the door, and that clearance varies, again, based on the push side or pull side. Next slide. So this is a table. I am not going to go through and read the entire table, but this is the maneuvering clearance at doors and gates table. And what it addresses is the type of use, and then the minimum maneuvering clearance for that use. And it addresses the approach direction, whether that is the perpendicular to the doorway or parallel to the doorway, and whether that is on the pull or push side of the door or gate. Note that there are 4 footnotes here, and that those are very important. So you need to be sure that you are knowing whether or not you are looking at a door or gate from the pull side or the push side, whether the maneuvering clearance is forward, hinge side, or latch side, and whether or not you need to add additional inches for a latch side, particularly if a closer and a latch are provided on the door. So you're going to need to be sure you note that when you have door clearances. Next slide. So let's talk a little bit about clustered areas that can be sort of an exception to the general new construction requirements that say everything must be accessible regardless of how many of them you have. So in new construction, you can have accessible dressing rooms and toilet rooms that are grouped together or clustered, and you can actually have a certain number that are accessible, and that does not necessarily have to be 100% if those dressing rooms or toilet rooms are clustered. So 5% of each type of dressing room, so that means if you have a men's and a women's, if you divide them by gender, 5% of each type of those has to be accessible, or at least one dressing room has to be accessible and comply with the accessibility requirements in ADA 803. Also, 50% of the clustered toilet rooms, or at least one, have to comply with the accessibility requirements for toilet rooms in ADA 603, which we're going to talk about in just a moment. The rooms need to be in the same general area, whether they are dressing rooms or toilet rooms, in order to get this exception, and they have to serve the same group of people. In other words, they have to be either public dressing rooms and toilet rooms or staff dressing rooms and toilet rooms in order to allow them to be clustered. You cannot have them serving different groups of people and allow them to be clustered and get this exception. Next slide. So again, we look at an overhead view of a medical suite here. And in blue, we see that we are showing some dressing rooms and exam rooms. So the dressing rooms, you have to have access to at least 5% of each type of dressing room. If you divide it by gender, that's got to be each type. And the exam rooms, 100% of those have to be accessible in new construction. Alterations are different. We're not going to really talk about alterations today, but in new construction, 100% of the public areas need to be accessible. And then you can, again, have 50% of the toilet rooms, if they're clustered and if they serve the same people, be accessible. And again, that 50%, you would, if you had like 7 of them, you would need to make sure that 4 of those are accessible and not just 3. Okay, next slide. So again, this is showing some clustered toilet rooms from overhead, and it's showing that at least 50% of them are accessible when they're in one location and serving the same users. Next slide. So toilet rooms that are covered in section 603, it's important to note what the accessibility requirements are for toilet rooms, and we're going to go over some of those now. But generally, you will have in a toilet room, and I'm not going to really address multi-accommodation or multi-stall toilet rooms today, because in most medical facilities, unless they are a very large medical facility, mostly what you are encountering is single-user toilet rooms in most of these medical facilities. So that's what we're going to address today. Of course, you can always call us at 1-800-949-4232 or email us if you have questions about multi-accommodation toilet rooms. But here you're going to have to make sure that your lavatory, your mirror, your water closet or toilet are accessible, that the dispensers and receptacles are accessible, that the grab bars are accessible, and that there's a turning space, either providing a 60-inch circle or a T-turn. Also, you need to make sure that coat hooks and shelves are accessible. And if you have more than one urinal in a toilet room, then that urinal would need to meet accessibility, at least one of those would need to meet accessibility requirements. Next slide. So exterior door maneuvering clearances, when you're getting into a toilet room, again, you need to make sure that if it's on the push side with a closer and a latch, that you have 48 inches perpendicular to the door of clearance and a 12-inch latch side or strike side clearance. If it's on the pull side of the door, you need 60 inches minimum perpendicular if you're doing a forward approach. And you also need 18 inches of latch side or strike side clearance if you're on the pull side of the door for the exterior door maneuvering clearances. Next slide. So in toilet rooms, you need to have clear floor space at the toilet, and this yellow area is showing the clear floor space that's required around the toilet for approach and transfer. Keep in mind that if you have multiple toilet rooms, you should really provide a transfer space on both sides of the toilet. So one on the left side of the toilet and another toilet room can provide a transfer space on the right side of the toilet, so that if people transfer in a certain way, they have an option whether they want to transfer left or right, and you can tell them which toilet room offers that option to them. So generally speaking, the toilet room clearance for the water closet needs to be 60 inches minimum perpendicular from the side wall, 56 inches minimum perpendicular from the rear wall. And then, of course, the seat height of the toilet needs to be 17 to 19 inches above the finished floor. And the center line of the toilet should be between 16 and 18 inches. This is another area where your state code may vary. Next slide. Also note that the toilet paper dispenser needs to be 7 to 9 inches in front of the water closet front edge, and the dispenser where the toilet paper actually dispenses should be 15 inches to 48 inches max from the floor. And then also note that if you have any protruding objects in this toilet room, like for example, a paper towel dispenser that would not be over the sink, it might be in this area at the bottom of this figure that we are showing, and it might be on a circulation path. So if you have a paper towel dispenser that sticks out more than 4 inches, that can become a protruding object. So you need to be sure that you have some warning for that person at 27 inches or less below that paper towel dispenser, or that you recess that paper towel dispenser so that it does not become a protruding object. Also here we see that there's turning space requirements. So elements with knee and toe clearance, and that includes the lavatory, can overlap, that fixture clearance can overlap the turning space for either a 60-inch diameter circle or a shaped space. And note that the door can always swing into the turning space and to other fixture spaces as long as you have at least a 30 by 48 inch clearance for a wheelchair to be clear of the door when it swings in. Next slide. So at a lavatory, this is showing the clearance at a lavatory. And that generally needs to be 30 inches wide by 48 inches long. And you need to provide knee and toe clearance under that lavatory. And those requirements can be found in 606. And also the knee and toe clearance can be found in 306. So it's important to understand what those requirements are so that someone can pull up and be able to use the lavatory, be able to reach the faucet. The faucet controls, of course, should be no more than 5 pounds to operate and not require tight grasping, twisting, or pinching of the wrist. And you should be able to have the pipes wrapped so that people who cannot feel the heat of the hot water on their legs will be protected from any hot water that comes through. So that's very important. Next slide. Also, again, the maneuvering clearances, it depends. This is showing a pole side clearance, and you have to have 60 inches of perpendicular clearance and 18 inches beyond the latch of the door so that you can actually be able to open the door and maneuver around to exit the door. Next slide. So you cannot have overlap of lavatory and toilet clearances except with a very small amount. On the left, you see a toilet and a lavatory that are mounted on the same wall, and their clearances can overlap just slightly, but you need to be sure that that toilet maneuvering clearance is really pretty clear of any other objects. You also can note that there are grab bars here. There's a rear grab bar that's generally 36 inches long, but you can have a shorter 24-inch minimum rear grab bar. If you recess the sink, if you recess the lavatory, then you can have a 24-inch minimum grab bar behind the toilet. But basically the side grab bar should always be a different length, okay? So, and there's definitely specific requirements for how long these grab bars need to be, where they need to be in relation to the water closet, how high above the floor they need to be. All of those are requirements that need to be looked at in the ADA standards. Okay, so next slide. So keep the swing of the door and the clearance for that swing of the door outside the fixture clearances, or at least provide a 30 by 48 minimum unobstructed clear floor space outside the swing of the door. They don't specify what location that has to be in. It could be in a location like this next to the toilet. It could also be at a diagonal area. So, but there needs to be at least a 30 by 48 inch minimum clearance outside the door swing. Next slide. So if you have a really small area and you want to add a toilet room, you can add an outswinging door, and that can allow for a smaller room size. It requires less interior maneuvering clearance, but you still need 12 inches minimum latch side clearance or strike side clearance on the push side if you have a door that opens, you know, on the push side from inside the toilet room. So you still need that latch side clearance. That's going to be important. Next slide. Okay, so that's the bottom line. General information about toilet rooms. Of course, there are lots of things that I didn't cover, and you can certainly call us about those other measurements. So moving on to accessible check-in areas. When you first come into a medical office or even a hospital, you're going to have a check-in area. And almost always you're going to have a counter. So that counter has to meet the following: a portion of the counter surface that is 36 inches long minimum and 36 inches high maximum above the finished floor needs to be provided. So typically we recommend using the entire counter surface at this 36-inch height, but you can have a portion of it at 36 inches high as long as it's at least 36 inches long. And you have to have a clear floor or ground space that complies with ADA 305 for that counter. It can be a parallel approach that is adjacent to the 36-inch minimum length of that counter, or it can be positioned for a forward approach. But when you position a counter for a forward approach, you must have knee and toe clearance that complies with 305. Next slide. So, in talking about accessible examination rooms, in new construction, we learned earlier that accessible exam rooms need to comply with all requirements for new construction. You cannot say that you can have clustered examination rooms. So what you must have in an examination room is an accessible route to the exam room and through the room. And remember, that has to be 36 inches wide and unobstructed. You also have to have an entry door that complies with all the door requirements that we learned earlier for width, maneuvering clearance, and accessible hardware. You have to have appropriate models and placement of examination equipment. And although you are not required to have adjustable examination equipment, and we're going to learn about medical diagnostic equipment in a moment, it is best if you can have adjustable examination equipment so that it at least adjusts on the height so that people are able to transfer. You also need adequate clear floor space inside the room next to the examination table and any other examination equipment that is there so that someone can make a side transfer either independently or if you need to use lift equipment, you need to be sure that you have plenty of space inside for the use of lift equipment. Next slide. So let's talk a little bit about medical diagnostic equipment. So these are standards that were issued by the U.S. Access Board, and they are found in the Rehabilitation Act, not in the ADA, but in the Rehabilitation Act, Section 510. They provide technical and scoping criteria for medical diagnostic equipment, but they right now are voluntary unless they are adopted by an enforcing authority. So it could be Department of Justice may eventually adopt these under the ADA, also Health and Human Services under the Rehabilitation Act. They also can be used by the Food and Drug Administration to verify labeling claims on medical diagnostic equipment. Because often people will claim that something is quote unquote ADA accessible or medical diagnostic equipment standards met, even though it may not actually meet those standards and it may not at all be ADA accessible, particularly if it's equipment. Next slide. So the equipment that is covered by the medical diagnostic equipment standards or guidelines in this case, for the ADA purposes is our examination tables, examination chairs. So they could use chairs that even go prone and could be converted into a table. Also examination chairs in dental offices or for optical exams. These are equipment that could be covered. Weight scales could be covered. And I can tell you that many people in wheelchairs for a long time went without being able to be weighed in a doctor's office. And that's really important to have that accessibility. Also, the medical diagnostic equipment standards cover X-ray machines, mammography equipment, and other medical diagnostic equipment. Next slide. So equipment that is not covered are personal devices, and on the left we see a photo of a blood glucose monitor. So that would not be covered by the medical diagnostic equipment or an insulin pump or anything that is personal that a person might use. The standards also do not apply to positioning aids. So once you are actually on that medical examination table that is covered by the medical diagnostic equipment standards, they may actually add some positioning aids to assist you with being positioned in the right place. Those positioning aids do not the medical diagnostic equipment standards do not apply to those positioning aids. Next slide. So the technical requirements depend on what the patient position is for the use. So they could be supine, prone, or side lying, meaning basically that they're lying down on their back or front or on their side. They could be seated, they could be in a wheelchair, or they could be standing. And there are different sections that apply for depending on whether the person is lying down or seated or in a wheelchair or standing. These standards also address supports like railings and other supports. They address communication, and they address operable parts as well. Next slide. So this is an example of adjustable heights for a supine, prone, or side-lying transfer service of a table. And you need to have a high height of 25 inches, low height of 17 to 19 inches. So that would be an adjustable table that could go from low of 17 to 19 to high of 25 inches. And it needs to have at least 4 additional positions separated by 1 inch heights. So different heights that can be adjustable. Next slide. Also, if you're seated in a wheelchair and you need to be able to access, for example, a weight scale, which is what is shown here, you need to be able to have pass-through, entry, and exit. So you can have a raised platform and edge protection. You have to have a little ramp that gets you onto the entry of this seated item. And you need to have 40 inches minimum of space where you're seated and there's no changes in level, no cross slope, no forward slope. So 40 inches minimum for that platform outside of the ramp surfaces. Next slide. And there can also be standing medical diagnostic equipment. That needs to have a slip-resistant surface. It can have vertical support gripping surfaces of 18 inches long minimum that are 34 to 37 inches height above the floor. That's the lower end of the gripping surface. They can also have horizontal support gripping surfaces that are 4 inches long minimum and 34 to 38 inches height to the top of the gripping surface, as we see here on the right-hand side. Also keep in mind that tables where you lie down or sit can also have railings to provide assistance with transferring on and off the table. And it should be really important that staff are trained in how to assist people in transferring to these tables and other medical devices, and are trained in using them, particularly if you're going to use a lift to move somebody from a wheelchair onto an exam table or an x-ray table of some kind. The staff needs to be trained in how to use that equipment and use it safely and carefully. Next slide. So it's important to note that most medical providers do actually pay taxes. Most are private. If they are government, that obviously they do not receive tax incentives, but if they are private, there are tax incentives that are available to businesses, including healthcare providers. And that tax incentive can be for physical accessibility changes, transportation accessibility modifications if you're providing transportation to your facility, and communication accessibility expenses for providing sign language interpreters, for example, or maybe making Braille transcribed information. So those are all tax incentives that are available. I have given you a website at the ADA National Network. It's a quick tips on taxes. So you can find information there. And we also always recommend that you consult your tax professional to make sure about whether you qualify for these and how much of a tax incentive you will receive. Next slide. I have also given you a list of resources here, a link to the 2010 standards, which we have gone over. A lot of what Emily and I have addressed here are in the 2010 standards. There is also a section or a document at the U.S. Access Board that addresses medical diagnostic equipment, and I have given you the link to that here. Also, you should note that the ADA National Network, which we are all a part of, has a website that you can access at adata.org. I have also given you the websites for the Rocky Mountain ADA Center, where Emily is from, and for the Pacific ADA Center, where I am from and where Lewis is from. So we hope that you will utilize these resources, and again, that you will contact us at the phone number or our email address and let us know if you have questions that we can help you with. Thank you.
All right, thanks so much, Jan and Emily. All right, so everyone, this would be the time to submit your questions in the chat window, and we'll get to those in a moment. Pardon me. So here's a couple of comments that have come into the chat window so far. Going back to the parking, we have a comment that there is an application of the 10% parking requirement to outpatient facilities on a hospital license, even if it is in a separate freestanding building. So that was something that somebody wanted to be shared. Next comment, or next question here, going back to the elevator exemption. The question was about what about educational facilities, community colleges, etc.? Are these government facilities when you were talking about the government facility exemptions?
Yes, as I explained, government facilities are an exception to the exemption. So that is, if it's a community college, that's almost always going to be a Title II or a government facility, and that will not have an elevator exemption. So remember, government facilities can only have an elevator exemption if they have only 2 stories, and if there's only 5 people or fewer that occupy that second story. And that's almost never going to be the case for most government facilities. And again, state law may govern that and may say something different.
Okay. And let me just remind you while you're writing, everyone, while you're writing in your questions, the slides are available right now at the adapresentations.org website. A lot of their information was very specific and referred to sections of the 2010 standards that you'll want to look up if you need it. So you might want to get the slides. They are in the healthcare section, in the schedule area of the healthcare section right now. By tomorrow, it will be in the archive section. Okay, and for those of you who did sign up and requested a certificate, that certificate will happen at the after the conclusion of today's session. All right. So one thing to ask you both is some of what you talked about, and you actually said this is for new construction. So are there? I mean, you can't cover everything, I'm sure, but what kinds of information might we know about if there were modifications to existing facilities that might apply here?
Emily, did you want to readdress what you talked about with regard to readily achievable barrier removal?
Sure. So yeah, these regulations do apply to existing facilities. Generally, that's going to happen when there is a major alteration to a facility. Then the requirement is that they comply with the 2010 standards. But even before a major alteration is put into place, both Title I and Title II entities have some requirements or have some responsibility to make readily achievable barrier removal. It's quite a mouthful. So that means, what they can do to provide access to people with disabilities, they need to do.
Yeah, and I think I just want to clarify a moment, Emily. It's generally places open to the public that are Title III facilities that would have readily achievable barrier removal. Of course, a Title II or a government facility would have program accessibility requirements that they would have to meet to make sure that they were providing accessibility. And there's lots of different areas about alterations that we just do not have time to cover today.
Right, yeah, a Title II, their program as a whole has to be accessible, which might entail removing barriers, architectural barriers, or relocating programs to accessible locations. But Title II is more of a programmatic focus, and then Title III is the readily achievable barrier removal.
Okay. And Jan, were there anything that you wanted to add about the interior of the building? If they were going to be doing alterations?
Well, of course, with alterations, there are some exceptions. For existing buildings, you may not be able to do something that is technically infeasible, but that's going to be, a pretty big exception, like, for example, if you have a plumbing code that requires you to have a certain number of toilets in a multi-accommodation toilet room, and what you would need to do is to remove one of those toilets or water closets in order to make enough space for a wheelchair accessible toilet room, it's possible that could be technically infeasible, but you're going to need to look at what else you can do besides what is technically infeasible in order to provide that accessibility, even when you're making an alteration. And there are also requirements that you should note for having to spend 20% above the cost of the alteration in order to address the accessible route or the path of travel. And that is really important to note in these medical facilities as well. So again, alterations can be confusing. They are very specific to the particular area or a particular building that you're talking about. And you should really call us or email us so that we can discuss that further with you.
Okay. Next question. Regarding parking at a university that's its building is 3 stories, what's the ADA requirement for that? For parking?
So I guess I would ask to clarify, is there parking garage that's 3 stories, or is it just that the building is 3 stories?
Okay, so Dora, this is your question. If you want to type in if this is if you're talking about a building that's 3 stories or a parking garage that's 3 stories. Okay. And so we'll wait for her response there. In the meantime, other questions, please send those in. And okay, the building garage, she says, is a parking garage with 3 stories.
Okay, so in that case, so you would calculate the accessible parking spaces based on that table that I showed, and they would need to be dispersed so that they are along, provide access. They're on the closest accessible route to an accessible entrance. The exception to parking garages is that you can cluster all of your van accessible parking on one level. And I believe that's because of the height requirement for van accessible parking. So you might have your first level of your parking garage meets the height requirement, but the other levels don't. So that's why you're able to cluster all of those on one level.
Okay, great. All right. So thanks very much. All right, so we realize that many of you may still have questions for our speakers, and apologize if you didn't get a chance to ask your questions, but do remember to contact your regional ADA center at 1-800-949-4232 to ask any questions about more specifics about this. And as Jan and Emily mentioned, sometimes there's state specific kinds of issues that you might need to know about, and your regional ADA center would know about those. You will receive an email with a link to an online session evaluation. Please complete that evaluation for today's program, as we really value your input and want to demonstrate the impact of this to our funder. We want to thank Jan and Emily today, our speakers, for sharing their time and their knowledge for us. It was very information-packed. So, but a reminder for all of you that the session was recorded. It will be available for viewing next week at adapresentations.org in the archive section of the health area. On our next webinar on August 27th, we'll be joined by the Office for Civil Rights of the U.S. Department of Health and Human Services on enforcing disability rights authorities. We hope that you can join us for that. Watch your email 2 weeks ahead for the announcement of the opening of that registration. Again, thank you, Jan and Emily, and thank you all for attending today's session and spending part of your afternoon with us. Have a good rest of your day. We'll see you in August. Bye-bye.